Good morning, everyone. How are you guys doing this morning? Good. Everybody having a good end of their summer? Well, thank you for joining us this morning. 2 months ago, we ended up doing starting on thoroughly through the CDC guidelines and what they've recommended for opioid prescribing. And today, we're going to go further into the recommendations. As always, anytime I present, if anybody has any questions, comments, concerns, please feel free to stop me and ask questions. That's what this is about, is for us all to learn and to have a conversation on how we can do things better. Before I get started, does anybody have any cases that they would like to go over or discuss this morning on a patient they've seen recently? Nope. I actually have a case that is that I'm probably going to deal with today, and I just want to get people's input. And so, if you guys don't mind, before I go into the finish or go further into the CDC guidelines, I want to just discuss this and just get everybody's opinion on what. All right. Well, you guys, let's go into my presentation now. Thank you guys for your input. I got the remote there. You're right. Oh, there it is. All right. So quickly, you guys, this is part 2 of our CDC guidelines. As always, here's my contact information. If anybody has any questions, concerns, worries, don't hesitate to email me. As we previously discussed, in America, do we have a drug misuse or abuse problem, or is it all just hype? I think we've all realized that since the changing paradigms that we saw in the 90s, it led to a decade of increased opioid deaths, which has now led to the CDC publishing their guidelines. As we know, these are targeted for primary care physicians because we saw an increase in pain medication dispensed by them over 2007 to 2012, and nearly 50% of all dispensed opioid prescriptions come from primary care physicians. And so these guidelines were written in order to provide guidance to primary cares on how to prescribe pain medications for pain that's outside of cancer treatment, palliative care, or end-of-life care. And the recommendations have been broken down into 3 different categories. The first category was determining when to initiate or continue opioids for chronic pain. We discussed that last time. Today, we're going to go over category, their second recommendation, which is opioid selection, dosage, duration, follow-up, and discontinuation. And 3, the third, which we'll do next month, is assessing risk and addressing harms of opioid use. So let's talk about opioid selection, dosage, duration, follow-up, and discontinuation. So under this section, the first recommendation that the CDC makes is that when you start opioid therapy for chronic pain, the provider should prescribe immediate-release opioids instead of extended-release long-acting opioids. Does anybody here in the panel, or does anybody here prescribe long-acting opiates? How about the Center of Complex Care? Do you guys do immediate release only? Do you guys prescribe long-acting pain medications?
We definitely prescribe long-acting medications, especially for patients on some immediate release medications, and they're requesting more and more. At some point, it's inappropriate to continue the immediate release medication, so I'll suggest starting them on a long-acting. Depends on the patient, though.
Yeah, and that's a good, and we'll see in the recommendations, they said that if patients are failing short-acting or not getting enough sustained relief, that a long-acting is a good option. I like long-acting or extended-release medications for one reason, and that is I believe that it stops the pill-taking behavior. But I think that a lot of times, what do immediate-release medications do? We take them, and it causes that euphoria. You take a pain medication, within 30 minutes, you kind of get that release of endorphins, which makes you feel good. And then, so I feel like the more short-actings you give patients, the more they're chasing that continuous high, and the more you put them on what I describe as a roller coaster. They're up and down all day. And my goal of putting a patient on a long-acting is to get rid of the roller coaster and make them more sustained, so that the opioid is in is on a constant level in their blood, so they feel like they get better around the clock coverage. A lot of times I see patients who are on too many short actings that they end up going through withdrawals in the middle of the night and have to wake up in the middle of the night in order to take pills to continue to get rest. And I think long actings are a good way to make it that you can restore their sleep cycle to a certain degree.
From a behavioral standpoint, they're reinforced for taking the pain pill on a short-acting level. And when you change that to an extended release and they stay time contingent, they're not rewarded for a big drop in their pain, thus not increasing the likelihood of using the med.
Yeah, the pleasure pathway, I think, gets stimulated with the pain medications, and I'm trying to short-circuit that pathway and hopefully make them more functional. The hard part with starting them on a long-acting is I noticed that in order, it takes 2 to 3 months for them to kind of stabilize or get away from that, that pathway being tickled. And unfortunately, a lot of patients are going to be non-compliant because they like that euphoria. They like that release of endorphins. Is there a question?
Yep, I have a question. So, in you saying that, what is the appropriateness of keeping them on their short-acting when you do change them to a long-acting, since it does take 2 or 3 months? How do you adjust those appropriately so they're not having the increased pain when you switch them over?
When I put a person on a long-acting opiate, what I end up doing is I immediately cut their short-acting down to probably no more than 2 or 3 a day. So I'll take an opioid calculator, and I will look at what they're on. And usually, what I try to do is I try to flip them to a different molecule. The great part about doing that is there's no cross-tolerance between classes of opioid medications, meaning that just because you're tolerant to oxycodone doesn't mean you're tolerant to MS-Contin. So say you have a patient who's on 100 milligram morphine equivalents of oxycodone. I could probably flip them to morphine and probably reduce their dose by 50%, and they'll still get good pain coverage. Does that make sense?
Yeah.
Yeah, if I did a 1-to-1 conversion from one pain molecule to another, the potential overdose is increased significantly. So if I cut them back by 50%, and then I give it at least a good 5 half-lives, which I always tell patients I won't increase or change the medications for at least a week. They have to stick that regimen out. It's very rarely that in a week do I get a phone call asking for an increase. I had another provider that I've worked with previously who would try to make that transition with patients and tell them that they could call at any moment. And he had a problem with patients coming in within 2 to 3 days and them exchanging medications or going back on their old regimen. And I saw, so he probably had 7 or 8 out of 10 that he would do come back in and demand their old regimen back. Me telling them that they had to give it at least a week, I probably would see, 1 out of 20 would come back in a week. The ones who did come back, a lot of times, then I'd probably look at a 10% increase at that week that I'd already had in my back pocket, that if they called, I would bump them up like 10%. And usually after that, the patient would be very happy. My goal of making them wait a week is I know that since I'm bumping them down a little bit, they may go through slight withdrawals, nothing life-threatening. And if I gave them that minor bump, it would probably make them feel better. And overall, I would have reduced their opioid consumption by 40% without them knowing it. So I think that's a very good strategy to utilize if you do go to a long-acting. The goal, once you get them on the long-acting, then, is once they've kind of stabilized, and they don't feel like their pain is covered, my goal then, say I've got them on MS-Contin twice a day and a short-acting twice a day, and they come in a month later and they feel like their pain isn't being controlled, I will bump up the long-acting at that point, and I will actually decrease the short-acting even further, maybe just a once a day. A lot of times what you'll see is patients still want that euphoria with the short-acting, even though by now that short-acting is probably just a drop in the lake, and they don't realize that. A lot of times, I'll give them the option. Well, hey, here's what I can do. You're complaining. We can stay where you're at. Or if you really don't think your pain is covered, I'm going to increase your long-acting and decrease your short-acting. And I guarantee you 9 times out of 10, the patient will stay where they're at, which is kind of a Jedi mind trick for me to convince the patient to stay on the regimen that they're at without increasing. Do you have a question? Okay, I thought I saw a hand go up.
Yeah, I'm sorry, I have another question. So, do you find patients, do you have them just on long-actings and not on any short-actings for breakthrough pain? Is that ideal?
Well, in an ideal situation, if I can get them on strictly nothing but a long-acting with no short-acting, that would be ideal. Problem is you're going to have patients who, are going to complain about their breakthrough pain and are going to hound your office with phone calls. So I try to enable the patient or give them some power. Does that make sense? To make them feel like they have some control over their pain. So if they do have a bad day, that they have some short-acting they can take. And that's more probably to make it easier on myself and my staff. There are some patients that are high risk, and I don't trust them in taking their short-acting opiates, and I will decline to put them on a short-acting because I'm afraid of the risk of them just overtaking the short-acting, and so I think having them on long-acting and let them be stabilized is a good situation. And you don't have to use, for breakthrough pain, you don't have to have a short-acting opiate. I mean, you can give them, ibuprofen, or some form of an NSAID to take as needed so they don't take it on a consistent basis. The other thing that I consider sometimes is, we've talked, I think, previously about how muscle relaxants, that class of medications is a misnomer. There's only 3 true muscle relaxants in that class. The benzos, Valium, tizanidine, and baclofen actually have only shown clinical studies to relax muscles. The other medications actually just work on the pain pathways. So sometimes giving them a muscle relaxant, that to kind of, for breakthrough pain is another good strategy as well. But let's delve deeper in what the CDC said here. So their reasoning behind not starting patients on a long-acting is that they said that clinical evidence that they reviewed showed that there was a higher risk for overdose among patients initiating treatment on long-actings. And I think that makes sense. If you have a patient who's not on anything, it's not reasonable for them to come in, complain of pain, and instead of initiating a short-acting, you shouldn't put them on a long-acting immediately. And they also showed that when they looked at the evidence that extended release or long-acting opiates were not more effective, safer, and they did not risk or reduce the risk of misuse or addiction. So even though we see, well, we'll go into it further, a lot of the long-actings that we see now are abuse deterrent, correct? And they came back and said that when they reviewed this, that abuse deterrent formulations are expected to make manipulation of the opioids more difficult or less rewarding, but they did not prevent abuse through oral intake. So if the patients are still taking the medications, orally, it's not going to prevent it. It's just going to prevent them from crushing it, snorting it, chewing it. They further said that abuse deterrent labels do not indicate that there's no risk of abuse. Some of them still can be manipulated. It just takes a little bit more of an effort. And lastly, they said that abuse deterrent does not prevent unintentional overdose through oral administration. So even though we have the drug reps promoting that, hey, we've got these long-actings are abuse deterrent, it doesn't necessarily mean that they're safer for your patient. The other thing that they talked about is how the FDA in 2014 modified the labeling for extended release and long-acting opiates. And actually, around the same time the CDC guidelines came in, the FDA has modified the labeling now for short-acting. So I believe the labeling is the same for long-acting and short-acting. But the CDC in this case, stated that the FDA said that, long-acting opiates should not be used for as-needed pain relief. And I think that's a good suggestion. It's interesting how I see some patients that get referred to me, and they'll be taking OxyContin for breakthrough pain, or their doctor will give them up to 6 a day, and they can kind of take them, as needed. That's not the purpose of extended releases. You should never prescribe them on an as-needed basis. Secondly, the FDA said that that when you start only when immediate release opiates are you should only start these when they're ineffective. So that's kind of like what we were discussing earlier. If you have a patient who's on a lot of short-acting medications, the pain isn't controlled, that is the appropriate time to start a patient on a long-acting opiate. or you should consider them when short-actings are not tolerated or provide inadequate pain management. The key with the labeling on long-acting opiates is that they say they want you to start these on patients who have chronic, moderate to severe, around-the-clock pain. So those are the perfect candidates for long-acting opiates. So bottom line, try to avoid extended release or long-acting opiates in combination with immediate release opiates is what the CDC has recommended. Can you do that? Yes. Is it going to be realistic in some situations? Probably not. That's why I probably try to limit the amount of immediate release opiates. The reason why they came out with this statement is they said that there is no evidence to show that, one, it would give patients better pain relief or function, and two, they thought the combination of the two medications may make the patient more vulnerable to overdose. The CDC also said that selecting an extended release or long-acting opiates, you want to predict the ones with predictable pharmacodynamics and pharmacokinetics. And so they basically recommended avoiding methadone and transdermal and fentanyl. Now, as we know, methadone is has got a very complex pharmacokinetics. Every patient metabolizes it differently. One person may take methadone and may be in and out of their system within 24 hours. Another person may take it and their body can't clear it and may stay in their system for 10 to 14 days. And since that's a trickier drug, they recommended that it should be avoided. Transdermal fentanyl, they said, is due to its absorption rate being faster over the first portion of the 72-hour period at which it's used. It makes the patients more vulnerable to overdose. And two, outside factors such as heat can increase its absorption, which may also make it dangerous. So they recommended avoiding both of those. Those are great suggestions. Unfortunately, I have to say I do like transdermal fentanyl, once again, because I try to stop that pill-taking behavior. So a lot of times when I feel like people have the Pac-Man syndrome, where they just see little white pills and like to eat them, I try to put them on fentanyl to stop that behavior. But they are right. Fentanyl, especially in summer months and heat and exposure to sun, it can leave your patient vulnerable to overdose. Any questions on this? Moving on, so the CDC did say that you should never start a patient on extended or long-acting opiates and never prescribe them for intermittent use. And like I said, the bottom line is you should only consider these for severe, chronic, around-the-clock pain. The next section that they talk about is that when opiates are started, providers should prescribe the lowest effective dose. Providers should use caution when prescribing opiates of any dosage that should implement additional, or providers should use caution when prescribing opiates of any dosage, should implement additional precautions when increasing the dosage beyond 50 milligram morphine equivalents a day, and should generally avoid increasing the dosage greater than 90 morphine milligram equivalents a day. Reasoning behind this is that they've shown that high-dose opiates in clinical trials showed no benefit. I guess there's only one clinical study that's ever been done, and it was a blinded study where they liberally increased patients' pain medications over a 6-month period versus a control group where they maintained their medications, their opiates at a steady dose. And what they found is that there was no difference between the groups at, I believe, 6 months in function or pain relief. So even though one group was liberally being increased on their pain medications over that 6 months, none of them had better pain scores or increased function compared to maintaining a group that they maintained on the same dose. The other thing is that the literature shows that as you increase medications with the higher doses they're on, serious harms come into play, specifically impairment and opioid use disorders and overdose. They also show that these patients have a higher incidence of motor vehicle crashes, abuse or dependence, and overdose. The literature from what they reviewed is that showed when patients are on 50 to 99 morphine milligram equivalents a day, that their overdose rate increased from 1.9 to 4.6 compared to patients who are on less than 20 morphine milligram equivalents a day. And once patients get over 99 morphine milligram equivalents a day, their risk of overdose increases up to from 2 to 9 times greater than patients who are on 20 morphine milligram equivalents or less a day. So kind of increases pretty exponentially the higher the dose patients get. So the bottom line, the CDC says that there is no single dose that is safe. So there is no threshold that we should say, oh, it's safe. But they thought that if you held doses less than 15 morphine milligram equivalents a day, that would more than likely reduce the risk among a large proportion of pain medication patients. So their recommendation is trying not to exceed 50 morphine milligram equivalents a day. They did say, though, that if you end up increasing a patient beyond 50 morphine milligram equivalents a day, that you need to know that the risk is increased and that it's not necessarily going to show an additional benefit of pain control or function. And then they said that you should generally avoid increasing past 90 morphine milligram equivalents a day. They talked about strategies too, that if you get above 50 morphine milligram equivalents a day, they should probably consider seeing the patient more often, more frequently. They also recommend at that point you should probably give the patient a prescription of naloxone. If they said if a patient needs to go above 90 morphine equivalents, you should utilize the same strategies, even consider seeing them even more regularly. And they said that more than likely you need to get pain management involved. That the cutoff of 90 morphine milligram equivalents is usually where you need to start looking at getting an expert in pain management involved in the patient's care. Any questions on this? Okay. So the next section the CDC recommended was that long-term opioid use often begins with treatment of acute pain. So when opioids are used for acute pain, providers should prescribe the lowest effective dose of immediate release opiates and should prescribe no greater quantity than needed for the expected duration of pain severe enough to require the opiates. 3 or fewer days usually will be sufficient for most non-traumatic and not related to major surgery. So why they came out with this statement is that they found that the clinical evidence reviewed showed that opioid use for acute pain has a correlation to showing that it ends up being prescribed for long-term use. And one of the beliefs that they think that why this occurs is that physical dependence can occur with being on the medication, with being on it just for a few short days. Have anybody changed their prescribing habits on this? So say a patient comes in and complains of lower back pain. Have you guys changed your practice and where now you only prescribe like a 3-day period of pain medications and to get them over the hump and encourage them to try other alternatives? Has anybody changed this? I think traditionally I've seen, where, patients will see their primary care provider for an acute pain issue and normally they'll say, oh, here's 3 a day and they'll give them like a 30-day supply. Yes? Go ahead. You get a question?
Recommendations from the FDA as far
as say that again, or get closer to the microphone. I can't hear you.
We have patients that need pain management and they need some short-term pain medication. And a lot of our patients, we look at putting them on some kind of an NSAID, but with all the FDA regulations, we're not saying that you should use the NSAID medication for cardiac issues. We're kind of at a loss of like what's next. But 3 days of opioid versus getting a patient on an NSAID when the FDA says that we shouldn't do cardiovascular risk.
Okay. So you're seeing individuals who have, let me repeat the question and make sure I understand this. So you're saying you guys are seeing individuals who have acute pain. Instead of putting them on opiates, you want to put them on a non-steroidal anti-inflammatory. But what you're finding out is that with the cardiovascular risks or the individual patients and their comorbidities, that's not an option, and so you guys are at a loss of what to put them next. Is that correct? Okay. I think that is I think you're right. That is a common scenario we see. Usually what I recommend in those situations is, and I'm getting more and more into this, is I've noticed that using the buprenorphine medications seems to be a better alternative. Does that make sense? So if I can put a patient on a Butrans patch or the subdermal or the sublingual buprenorphine, such as Belbuca, those are, now I'm not getting, as long as I'm not treating an addiction, I'm treating chronic pain. Those medications are indicated for chronic pain. Those are opioid antagonists, agonist and antagonist medications. And what I've seen is that seems to stabilize the patient. There is no craving for more medications. They're not as abused. Does that make sense? There is a street value for these drugs, and a lot of times your patients who are addicted to opiates and they can't get a hold of them, a lot of times they will try to purchase these medications on the street in order to extinguish their cravings and prevent them from going through withdrawal. But I think that medication is a good medication because it doesn't seem to start physical dependence because it's an agonist, antagonist, nor does it let that patient get the craving for the medication if they've never been exposed to it. Do you guys agree with that strategy?
The one thing that we'll just need to look into, one is cost, and two, if pays for that type of medication.
Let's say it one more time.
We'll just need to look into one, cost for our uninsured patients, and then two, whether or not the three medications.
I think yes.
I still couldn't hear you, sorry.
There's a concern about cost and whether insurance is going to cover those medications.
Oh, yeah. So, yes, that is a problem, right? A lot of these medications are newer. They're not Tier 1. Insurance won't cover it. So I'm currently part of the Opioid Task Force for the state of Nevada, and we're trying to make some recommendations to the governor, for his upcoming summit. And one of the things that we're looking to do is to make it mandatory, or maybe some kind of state law, that these types of medications should be first line, or the insurances should cover it. What's interesting is that one of my colleagues that I saw recently at a conference, he told me that in the state of Florida, they've already passed this type of law that insurance can't discriminate between generic versus the newer medications, which the newer medications, patients or providers for deeming them more appropriate or safer for their patients, that their state law makes it now that the insurances have to cover it. So hopefully we can get something like that here, but you are right, there is a balance of, certain patients can't be on certain medications even though that may be a better strategy for them based off of coverage. Okay. So here we go. Moving on. So bottom line, if you see a patient for acute pain, you should prescribe the lowest effective dose, and you should never prescribe the number of pills greater than how long you think that pain problem should last. And they're recommending that as a default, you should do less than 3 days of opiates for acute pain. And they also recommended against prescribing opiates for just-in-case pain, in case it lasts longer. It's interesting, I have patients that hit me up for this all the time that I'll, say I've done an epidural, their pain has improved, and, they'll say, hey, I don't think I need anything further, I'll call you when I need you. But hey, can you give me a prescription of Vicodin just in case? and usually I decline, which will make some patients upset. But the last thing we want to do is have we've seen that access, especially younger people, access to medication cupboards that have unused pills leads to diversion, and so we want to avoid having medications sitting around people's homes. The last recommendation under this section that the CD recommends is that providers should evaluate patients and harms with patients within 1 to 4 weeks of starting opioid therapy for chronic pain or any dose escalation. Providers should evaluate benefits and harms of continued opioid therapies every 3 months or more frequently. And if at any point the benefits do not outweigh the harms of continuing the opioid therapy, providers should work with the patients to reduce their dosage and discontinue the opiates altogether. And the reasoning behind this is that they said that the risk of opioid overdose are greatest during the first 3 to 7 days after an opioid is initiated or the dose is increased. 2, they said the risk of overdose associated with extended release or long-acting opiates particularly is high in the first 2 weeks of initiating this type of treatment. And furthermore, they said that the clinical evidence reviewed found that continuing opioid therapy for 3 months substantially increases the risk of an opioid use disorder. So bottom line, if you're going to start a patient on a pain medication, you should probably follow up with them after a week, or worst case scenario, 4 weeks after initiating it. They recommended that if you put a patient on a long-acting, you should probably see them 1 to 2 weeks after it started, since that's where the risk of opioid overdose is greatest. They furthermore said that if you do use methadone and you do start a patient on it, you should probably see them 3 days after initiation and consider getting an EKG before and after the medication is started to make sure that you're not causing a dysrhythmia or a prolongation of the QT interval. At these follow-ups, you need to assess the patient's function, pain control, and quality of life. Reason why they said that is that patients who do not get pain relief at 1 month in any clinical trial has never shown to get better pain relief at 6 months after being on opiates. So if you start a person on an opiate, they're not getting pain control at 1 month, you should discontinue at that point, because no clinical trials have shown that increasing it or continuing it any further is going to give the patient any benefit. The other thing that they said at these follow-ups is that you need to assess for common side effects as well as early signs of more serious problems. Specifically, they're looking to see, does the patient have slurred speech? Do they appear impaired? Ask family members, are they having a hard time, cognitively? Those are signs that maybe the dose is too high and the patient could have an adverse event such as an overdose if you continue that dose. Now, I understand in the rural areas, seeing the patients on a monthly basis isn't possible. They recommend that if they can't come into the office and you see them face-to-face, that maybe you do kind of like a telemedicine visit, a minimum of phone call to talk to the patient over the phone to get some feedback, or 2, if you can Skype with them so you can visually see how they're doing, that would be even better. The bottom line, the CDC wants you to constantly reassess the benefits versus the risks of long-term opiate therapy. You need to do this at least on every 3-month basis. And I don't have any of this written down, but they said that if at any point that the benefits or the harms are outweighing the benefits, then you need to talk about a taper. They said that the clinical evidence shows that you can reduce, there are studies that show that you can reduce 10 to 50% a week. They generally recommended against that. They said that you should probably do 10% a month. If while you're tapering, the patient needs a pause, meaning that maybe for a month or 2 you stop the taper, that's reasonable. That kind of allows the patient to get back to a better steady state before you resume the taper. Pregnant women, they said that you got to be, you should never, you should get an expert involved in tapering there. That the tapering in the withdrawal symptoms that a pregnant individual could experience could be life-threatening to the fetus. The last thing we want to do is cause undue harm to an unborn child. So you got to be careful in those situations. But they did say for patients who have severe side effects or harms, such as a recent overdose, that it is reasonable to give them a rapid taper over a 2 to 3 week period of time. Any questions on that? Any questions in general, or anybody want to go over anything else this morning? Well, I think that covers it. Next month, we'll go over the last section, which is assessing patient the risk versus benefits for long-term opioid use and how to do that. Well, I appreciate everybody's attention this morning. Hopefully it was helpful. The website should have the slides if anybody wants to access them or review them long-term. They're there for your pleasure.
And then real quickly, I just sent out a survey link in the chat. Do you guys have a second to fill that out? That would be awesome. Thank you.
Hey, thank you, everyone. I appreciate it. Have a wonderful day today.
You too. Thanks.
Thank you.